Welcome everybody to the Wednesday Grand Rounds series from the Norton Infectious Diseases Institute. And today is we have another excellent speaker, Dr. Matthew Song. That is a clinical pharmacy with a specialty in infectious diseases, part of the clinical pharmacist team and the antimicrobial stewardship team at Norton Healthcare, and also leading the efforts as far as the statewide program, CASIC, looking at how we can then improve antimicrobial use, decrease antimicrobial resistance and those emerging pathogens that are so problematic. So thank you for the work that you're doing on all of those fronts. So let me, Matt, turn it over to you today.
Thank you, Dr. Carrico. Like Dr. Carrico just mentioned, I'm one of the infectious diseases pharmacists here at Norton Healthcare, and my work is, I've been in this role since 2017, and my work has primarily been in antimicrobial stewardship. And part of antimicrobial stewardship is optimizing use to decrease risks of antimicrobial use. And so that's really what my presentation will focus on today, is describing some of the risks of antimicrobial use and really what antimicrobial stewardship can do to try to prevent that. And so to start with my presentation today, what I'd like to do is just read to you all the mission statement of the Norton Antimicrobial Stewardship Program. And it reads as, to optimize clinical outcomes while minimizing adverse consequences of antimicrobial use, including toxicity, selection of pathogenic organisms, and the emergence of resistance, and to reduce healthcare costs without adversely impacting quality of care. And so that's really what my presentation today is going to focus on, those three risks of antimicrobial use: the toxicity, selection of pathogenic organisms, and the emergence of resistance. But before I get into like an in-depth discussion of what the risks of antimicrobial use are, I want to start and just briefly discuss some of the benefits of antimicrobials. And to do that, I want to first introduce the case of Mrs. Ann Miller. And so Mrs. Ann Miller was hospitalized in 1942 with sepsis following a miscarriage. She had a fever of 103 degrees for several weeks, and despite receiving the treatments of the day, which included surgery and blood transfusions, she wasn't really getting better. Fortunately for her, however, her provider thought about using antibiotics, a relatively new treatment option at the time. And to provide some context, it's 1942 here, so this is kind of in the middle of World War II. Alexander Fleming had just discovered penicillin in 1928, and at the time there wasn't any mass production capabilities or distribution channels that would allow for penicillin or other antibiotics to be readily available at hospitals that they are today. And so she was really fortunate to have a provider thinking about this at the time. But he was able to get some for her, and despite again having that fever for several weeks, when he treated her with those antibiotics, she was noted to have defervesced within a day. Following that, she was able to get successfully treated and eventually discharged to the hospital. And she went on to live a long and happy life until 1999, when she passed at the ripe old age of 90 years of age. And I think what this case really signifies, it serves as a landmark, basically, is identifying the beginning of the antibiotic era. And so that's the era in which antibiotics are commonly used across the healthcare system, and where we can use them to treat infections or diseases that normally in the past we could not have. Fast forward today, and we see that exactly happening. Antibiotics are used across the entire healthcare continuum. And to really emphasize the benefit of antibiotics, I have a couple patient populations on this slide here that I want to discuss a little bit in greater detail. And so with sepsis, like the case of Mrs. Ann Miller, antibiotics along with supportive care continue to be the primary treatment modality for treating sepsis, and have resulted in dramatically reducing mortality and morbidity associated with sepsis. When we think about surgical patients, we often give patients who are undergoing surgery antibiotics prior to their surgery, and then to prevent infections. And in the unfortunate few who do go on to develop infections anyways, we still have antibiotics at our disposal to treat those infections and essentially preserve the benefit of having the surgery, is kind of how I like to think about it. These next two patient populations, organ transplantation and cancer. And so when we think about these patients, these are honestly, organ transplantations has always been something I've thought is pretty honestly a great example of the modern miracle of medicine, But when we think about these patients, in order for them to successfully receive an organ transplantation or have successfully treated with cancer, we often give them medications that are highly immunosuppressive to the point that they place these patients at higher risk for developing infections. And so even with these benefits, we have these antibiotics still to treat these infections as they arise, or in some cases, prevent infections before they occur. And similar to surgery, I would say that the benefits of antimicrobials here are that they are actually preserving the utility of organ transplantation or cancer. When it comes to dialysis patients, this is one that's uniquely at risk for certain infections or many infections. You think about a patient who goes to a dialysis center several times a week, and when they get to the dialysis center, they have essentially the entire contents of their intravascular system run through machines and then filtered, placing them at great risk for certain infections, particularly endovascular infections. The role of antibiotics is significant for them as well. And then lastly, in patients with comorbidities, such as those with diabetes or chronic heart disease or chronic lung disease, these patients are not quite immunocompromised, but they also are not quite the same level of normal immune system, like maybe myself or a lot of you in attendance. But they're at higher risk for infections as well. And again, the benefits of antibiotics are dramatic for them as well. And so now that I've discussed many of the benefits of antibiotics, this really leads me to my first major risk, and it's one that I'm pretty sure everybody here is quite familiar with, and that's really the risk of antimicrobial resistance. And so when we think about antimicrobial resistance, I just have a couple clips here from the CDC. It's essentially when the germs, the bacteria, or the funguses, or fungi, or viruses develop the ability to defeat the antibiotics or antimicrobials designed to kill them. Often what happens is that this results in the infections being either more difficult to treat or in some extreme cases impossible to treat. And when we think about when we try to quantify the entire impact of antimicrobial resistance, the CDC just recently released a couple years ago their antibiotic threat resistance report. And from those numbers, we see that annually, almost 3 million infections are now being caused by antibiotic-resistant bacteria and fungi, and that's leading to almost 36,000 deaths annually. And so that's a pretty dramatic effect on our healthcare system. And so I think it's important to try to understand what are some things that we can do to reduce the risk of antimicrobial resistance. And from an antimicrobial stewardship perspective, there's 3 things I want to talk about today. So the number one being not starting or stopping antibiotics in patients who do not need them. A common example of this would be in situations where there might be a viral respiratory tract infection. And so the situation is usually in a patient in the outpatient setting. They have some runny nose, they have a sore throat, maybe have a fever, they go see their primary care physician, and we have significant data demonstrating that epidemiologically, these are far more likely due to viral illnesses, they receive an antibiotic nevertheless. And so that right there is going to increase the risk for antimicrobial resistance. And then another common situation, one we experience in the outpatient, in the inpatient setting as well, is the treatment of asymptomatic bacteriuria. And I would like to direct everybody to a presentation a few weeks back made by my colleague, Dr. Elena Swingler, who's the Addie pharmacist at Women's and Children's, who provided a broader overview of this topic. I will just say briefly here, this is the situation where a patient has no urinary symptoms, but has bacteria in their urine, and where we have several different guidelines and large pieces of data demonstrating that there is no benefit. These patients nevertheless receive antibiotics and only experience the risks associated with those antibiotics then. The next point of antimicrobial stewardship that I want to mention is stopping antibiotics in patients who no longer need them. And so when we think about durations used to treat antibiotics, in the past, a lot of them were not really based on strong data. But fortunately for us, within the past 5 to 10 years, there have been significant efforts in research in trying to identify more optimal durations of therapy. And from those research, we've seen that the vast majority of situations where infections are often able to be successfully treated with shorter durations as compared to longer durations. And so in short, shorter tends to be better. And then the next point I want to mention is using appropriate spectrum. And so when we think about infections, there are many different types of infections. And for each infection, there's usually either a handful or more of what we consider the likely pathogens. And so when we first start treating a patient who's diagnosed with that infection, we want to select antibiotics that have activity against the likely pathogens. There can be situations where we end up using antibiotics that have more than is necessary for those likely pathogens. And so there is important in trying to direct providers into using what is appropriate spectrum there. Similarly, after we diagnose these patients with these infections, after we get some microbiological data back, either we can identify the pathogen or pathogens, or we can fail to identify certain pathogens. And from that information, we should be trying to de-escalate that spectrum again to try to reduce that selective pressure and inducing antimicrobial resistance across many different pathogens. And then lastly, I would be remiss if I failed to mention the important role that infection and prevention and control play in reducing antimicrobial resistance. Whereas I think antimicrobial stewardship tries to stop it from the emergence, the reality is that it's unlikely that we are 100% successful in that endeavor. And then that's really where I see infection prevention coming in, is that after we see those patients developing those resistant organisms, we take the appropriate steps to stop the spread. Similarly, a lot of infection prevention and control work focuses on preventing infections altogether. I think a great example of that would be surgical site infections. And so the less surgical site infections that we can have, or the more surgical site infections that we can prevent, the less antibiotics we would end up using to try to treat those, and therefore adding to the selective pressure that might cause the emergence of antimicrobial resistance. And I will say, I've been doing this for a couple of years. I have colleagues who've been doing this for a couple of years. I know a lot of people on this call today are infection preventionists, and I'm pretty sure all of us can sit and agree and say, it's a lot of work. It's hard. And I think what I want to do then is just to say that our efforts are worth it. And so from the most recent CDC antimicrobial resistance threat report, we see that 18% of fewer deaths are now occurring to antimicrobial resistance as compared to the previous report in 2013. And then when we focus specifically on hospitals, we see that number increase to 28%. And in addition to that, when we look at certain antimicrobial resistant pathogens, we're seeing decreases across the board in VRE, MDR Pseudomonas, MRSA, carbapenem-resistant Acinetobacter, and drug-resistant Candida. We still have some work to do with carbapenem-resistant Enterobacteriales, but overall, I think this data is very encouraging and helps motivate at least me to continue in the efforts that we've been doing for these past couple of years. And just to bring it back home a little bit, here's some local data that I'd just like to demonstrate some of the benefits we're seeing with reducing antimicrobial resistance, or demonstrating that we are reducing antimicrobial resistance, is looking at our adult hospital levofloxacin susceptibilities over the past 10 years. And so when you look at the y-axis here, that's the percent susceptible. And then when you look at the x-axis, that's going to be individual years. The blue line indicates E. coli and the orange line indicates Pseudomonas aeruginosa. And so we've had, at Norton Healthcare at least, we've made significant efforts in trying to do fluoroquinolone stewardship. And I think this well demonstrates the fruits of our labor. And so when compared to 2010, when our susceptibility rate to E. coli was around 65%, 10 years later, we saw it now has improved to about 75%. And given the frequency in which E. coli is identified as a causative pathogen for infections, this is quite the tremendous improvement in susceptibility rates. Similarly, when we look at Pseudomonas in 2010, it was actually around 52%. And then in 2020, it got all the way up to 82%. And so roughly that's about a 30% reduction in resistance in Pseudomonas. And when we take into consideration that quinolones are actually the only oral option to treat Pseudomonas infections, to me, that's a dramatic improvement. That's a 30% reduction in potential line use for outpatient antimicrobial therapy. And again, a very encouraging data demonstrating that we are being successful in all of our hard work in reducing antimicrobial resistance. With regards to the next toxicity, or the next risk I want to discuss today, that's going to be antimicrobial toxicity. And an example that I want to use is simply just some of our local data here, mostly because I have access to it. But when we looked at the top 5 antibiotics we used at Norton Adult Hospitals in 2021, we saw that the number 1 antibiotic we used was vancomycin. And then following that, it was 4 beta-lactams, ceftriaxone, cefazolin, cefepime, and piperacillin, tazobactam. And really the point I want to make here is that these drugs are not benign. In fact, when we look at them, I have some select adverse events associated with the use of these drugs here. First and foremost, I want to note that this is not an exhaustive list. I'm sure if anybody's ever looked at a package insert, you see typically it's like a very long list, like a CVS receipt of different adverse events that may happen. But these are the ones that typically cause us the most trouble or the ones that we might think about in the hospital. And so common among vancomycin and beta-lactams, we can see allergic reactions, drug fever, hemolytic anemia, thrombocytopenia and pancytopenia, elevated liver enzymes. And then since all of these are intravenously administered antibiotics, we can see injection site issues. And so whether it be tissue extravasation or line complications such as thrombus formation or potentially even line infections, we can see those as well. And when we go specifically to the individual antimicrobials listed here with vancomycin, we can also see infusion reactions, nephrotoxicity, and ototoxicity. With ceftriaxone, there's some unique adverse events associated with calcium precipitation, manifesting as kidney stones, gallstones, gallbladder sludging, and pancreatitis. And then with cefepime, there's a concern with neurotoxicity. And with piptazo, there's been some recent literature in the past few years that are suggesting that there might be an increased concern with nephrotoxicity, sometimes in combination with vancomycin. And these are all important things to consider, but I think what really helps us understand the true impact of adverse drug events is how often are they actually happening. And what I'd like to do is present some information that was published in JAMA a couple of years ago that looked at the inpatient adverse drug events due to antibiotics. And so this was conducted at Johns Hopkins Hospital, and then they roughly had about 1,500 patients that they were able to look at. They saw that in patients who received antibiotics, IV antibiotics for at least 24 hours or longer, 20% of those patients went on to develop adverse events. And then really what's really profound about their data that I took away is that when we looked at when they developed their adverse events, we saw that while the majority of them did develop it during hospitalization, over a quarter of those patients developed them after discharge. And that's particularly concerning for me because if you're going to develop an adverse event, I'd much rather have you do it in the hospital where I can monitor you and where I can react to it in a much quicker way. But in these patients who are discharged, they might not be able to seek care quickly enough and develop additional complications because of that. Along those same veins, when they looked at the occurrence rates within 30 days and 90 days, we saw there was a slight majority within 30 days, but still a significant portion that occurred within 90 days. And so this is really just demonstrating to me that after you receive antibiotics, you're not necessarily in the clear immediately, and that you might need to be looking over your shoulder for a little bit. And then lastly, just to reiterate some of the benefits or the importance of antimicrobial stewardship is that they were able to assess these cases a little bit more deeply. And they found that of 20% of adverse drug events that did occur, they occurred in situations where antibiotics were deemed to not even be indicated at all. Thus, again, necessitating the need for antimicrobial stewardship. And to really further push my point or demonstrate my point, they were able to also discuss some of the outcomes associated with these adverse drug events. And we saw that while a smaller number, 3% resulted in new hospitalization, but then 9% resulted in clinic or additional clinic or emergency department visits. And then 61% resulted in additional need for monitoring, including lab, electrocardiogram, or imaging. And then lastly, 24% resulted in additional need for prolonged hospitalization. And so when it comes to it, antibiotics, while seemingly can be a small, little benign thing at first, can quickly snowball into much greater impact, such as additional hospitalization, resulting in more complications for our patients. When we think about antimicrobial use, we typically a lot of times think about inpatient, or at least I do. Some of you might be thinking more about outpatient. But the key here is that most of our antimicrobial use is actually is utilized in the outpatient setting. And so I have some additional information I want to present on the risks of outpatient usage. But before I do that, I just want to set the setting a little bit. And so in 2013 and 2014, Kentucky was the second highest outpatient prescribing state in the nation, second only to West Virginia. And then when we looked at the top 5 antibiotics prescribed nationally, they are demonstrated here. You see they're essentially the same with the flipping of trimsulfa in 2013 to cephalexin in 2014. But we actually see ciprofloxacin, a fluoroquinolone antibiotic, in the top 5 oral antibiotics prescribed nationally in those years. And to reiterate, quinolones are one of the more, I would say, concerning in regards to drug toxicities. The actual incidence is probably low, but when you think about what actually occurs, they're quite catastrophic. Just to list a couple things that may happen: hypoglycemic coma, tendon rupture, aortic dissections, QTC prolongations, central and peripheral neuropathies, including decreased seizure threshold. When we look at those drugs, they're really quite concerning. And so now that we have this outpatient antimicrobial usage data in hand, we can take a look at some data that was published a couple years ago regarding the emergency department visits due to adverse drug events in those years. And so this information comes from a national electronic database looking at adverse drug events reported from 58 EDs across the country. And this data represents information from 42,585 emergency department visits. And when we looked at all emergency department visits due to adverse drug events, the top 4 are listed here. We saw that antibiotics was actually the #2 most common reason someone was admitted to or someone sought care in an emergency department due to an adverse drug event. And specifically, when we looked at more individual age groups, we saw it was the most common in children aged 5 years or less, and also the most common in those aged 6 to 19 years. And then following emergency department visits, while overall antibiotics were actually not a big one resulting in hospitalization, when we compared the individual antibiotic classes, we saw that hospitalization following an ED visit due to an adverse drug event was highest among quinolones compared to all of the other antibiotics. And that really wanted to just reiterate that ciprofloxacin was actually one of those top 5 most common antibiotics used in those years, 2013 to 2014. And so when we think about how can we reduce drug toxicity from antimicrobial use, I'd like to reemphasize the role of antimicrobial stewardship. And the reality is that the actions are pretty much the same. So again, not starting or stopping antibiotics in patients who do not need them, stopping antibiotics in patients who no longer need them. But in these situations, another consideration comes to mind, and that's really selecting the less toxic antibiotics when able. And one example that I have for you all here is using amoxicillin clavulanate over levofloxacin for the treatment of pneumonia, specifically community-acquired pneumonia, as it covers all the same pathogens, but it has less those toxicities. And then again, I want to again emphasize the great role that infection prevention and control have in reducing antimicrobial toxicities. And it goes back to the idea of preventing infections. My example from earlier was preventing surgical site infections, similar to reducing the selective pressure that might come from using antimicrobials. If we can prevent an infection, we can prevent the exposure of those antimicrobials and any associated toxicity a patient might be put at risk for when using those. But luckily, I have some fortunate news. And so when I looked at the most recent CDC outpatient antimicrobial prescribing data, Kentucky had improved a little bit. We're still in the top 5, but that's still an improvement from #2. So now we're behind Alabama, Mississippi, and Louisiana, in addition to West Virginia. And then when we looked at the top 5 oral antibiotics prescribed nationally, I felt pretty good that quinolone was no longer among the top 5, and it was replaced with doxycycline. And so I think that is encouraging, and hopefully when they redo the emergency department visit study again in a couple of years, we can see some improvement in those data as well. And for the last risk of antimicrobial use that I want to discuss today, it's going to be the selection of pathogenic organisms. And really the best example of that from antimicrobial stewardship is going to be C. difficile. And a lot of the information I present here is going to be a reiteration of a lot of the great information that one of my colleagues, Dr. Sarah Moore, presented a couple weeks ago, I think in February, with C. difficile. But this is identified as one of the CDC's most urgent threats. And so this is the highest level of urgency that the CDC assigns what they consider resistant organisms. And then when we take a look at the impact C. difficile has on our healthcare system and our public in general, we see that about 224,000 cases were estimated to cause hospitalization in 2017, leading to almost 13,000 deaths and $1 billion in attributable healthcare costs. When we think more about the individual impact on an individual patient, I regurgitated this slide from Sarah's Dr. Moore's presentation about C. difficile and its impact on quality in life. And so we looked at this one survey that surveyed hospitalized patients with C. diff and compared them to the general population. We saw that patients were scoring significantly lower on physical health and mental health, and that these scores were associated with recurrent illnesses and severe illnesses too. And then, so when we think about how do we actually reduce C. diff, again, from the antimicrobial stewardship perspective, surprise, it's going to be the same things. And so, again, it's using antibiotics only when needed. So not starting them and stopping them when they're no longer needed or when we deem they're no longer needed, using those appropriate durations, looking at that evidence, particularly that most recent evidence, looking at shorter durations being just as good. And then similar to toxicity of antimicrobials, there are different antibiotics, or all antibiotics increase the risk for C. diff, but not all antibiotics increase the risk at the same degree. And so in situations when we can select the lower risk antibiotic, that is that has been shown to actually reduce the risks or the incidence of C. difficile. And then lastly, infection prevention, again, does a lot of work in stopping the spread and essentially the incidence and then the geometric growth and spread of an infectious disease. And unfortunately, recent data from the CDC is encouraging as well. And so we saw numbers peak in 2015, and then afterwards they come down. And then in 2017, with the most recent data report on the CDC, while it's still a large number, when we actually compare it to the 5 years prior, we see that actually it's the lowest number overall. And I find that encouraging, and hopefully we can see that number continue to go down. And so in summary, the risks of antimicrobial use include the development of antimicrobial resistance, drug toxicity associated with the use of antimicrobials, and selection of pathogenic organisms such as C. difficile. In terms of trying to reduce the risk of antimicrobials, we can, again, not start or stop antibiotics in those who don't need them, stopping antibiotics in those who no longer need them, selecting least toxic agents and agents with less risk of C. diff when we're able, and supporting and exercising proper infection prevention strategies to stop the spread of resistant organisms and preventing infections, and therefore the clinical need to use antimicrobials. And so that concludes my presentation today. I appreciate you all for having me. What questions can I answer?
That was excellent. So those of you that have questions, you can either unmute yourself, or if you prefer to put your question in the chat. We want to make sure that we can address this, because clearly you showed that not only is antimicrobial stewardship important across all settings, everywhere where healthcare is delivered, but also across the populations that are being served, whether we're talking about adult patients or pediatric patients, geriatric patients. And then you also focus on the fact that it is not the clinical pharmacist that is dispensing and many times helping to guide formulary development. It is not the sole responsibility of the clinical pharmacist that you talked about. You need drug susceptibility information. So we need that from the microbiologist. We need, appropriate specimen collection coming from the bedside healthcare workers. So when you begin to look at it, and you and Dr. Wild and the rest of the pharmacy experts that in infectious diseases, as you begin to really look at the guidance that we have from CDC and working with different facilities to begin to take a deeper dive in what they are doing, do you have maybe some high-level suggestions on what a facility can do if they are just beginning a stewardship program, or if they feel like they don't know where to go, what to do? Can you offer a little bit of guidance?
Yeah. So I think there's great resources from the CDC. So they have core elements of antimicrobial stewardship that define broad categories that what they suggest any hospital should have. There's that resource. There's a guideline from the IDSA that's also endorsed by the Pediatric Infectious Diseases Society and also the Society for Healthcare Epidemiology of America. And really, if you're local to Kentucky, I would highly recommend, we're really starting to develop it right now, but the Kentucky Antimicrobial Stewardship Innovation Consortium. And so this is a program that, that we have been, Norton Infectious Diseases Institute has been developing really at the start right now. But the idea is that we want to start reaching out and offering services, and then ideas, sharing ideas, offering mentorship, and then also helping facilities develop their own antimicrobial stewardship programs as well. And so I think those three would probably be the ones that stand out to my mind. I think if he hasn't already, David Bushman usually puts the website into the chat if you can. But if you go to that website, we have a little bit of contact information, but we will start actively conducting that to a higher degree and reaching out to everybody and trying to see what everybody, what needs are, and then trying to facilitate the improvement of antimicrobial stewardship programs.
Perfect, perfect. I know we've got a couple of questions, and Cheryl, I'll put the link to the CDC core elements, they'll take you to that website and all of the information then that's available on that web page. But if any of you are in facilities and you want to become increasingly more involved in this initiative across Kentucky, then you can certainly email me at ruth.carrico@nortonhealthcare.org. You can email Dr. Song, matthew.song@nortonhealthcare.org. Ashley Wild, Dr. Ashley Wild is the lead for the state initiative, ashley.wild with an E, wild, at nortonhealthcare.org, and we can help get some of that information to you. So one of the questions that we had was, what are some of the least likely antibiotics to cause C. difficile?
Yeah, so one, if you go to the Norton Infectious Diseases Institute YouTube channel, where Dr. Carrico has been graciously recording all these presentations, again, one of my colleagues, Dr. Sarah Moore, who's another one of the infectious diseases pharmacists, she gave a presentation actually specifically on C. difficile, and she had a couple slides in there to describe what were the different risk categories of antibiotics. But briefly here, typically it's usually going to be your more narrow spectrum beta-lactams, and so first generation cephalosporins, narrow spectrum penicillins like penicillin or anti-staphylococcal penicillins, doxycycline and other tetracyclines tend to be lower risk. Nitrofurantoin that's used for urinary tract infections is low risk. And then after that, there's a lot that fall within what are considered a medium risk. And honestly, it's better if I just tell you what's high risk, because everything else falls basically into medium risk. But really those highest risk ones are going to be third and fourth generation cephalosporins. So that's going to be like ceftriaxone and cefepime, clindamycin, quinolones such as ciprofloxacin, levofloxacin, moxifloxacin, and carbapenems. So meropenem, ertapenem, and those things. And so really not the low risk, not the high risk. Everything else is kind of medium risk.
Hey, Melissa Fortin has a good question that I know stumps clinicians across the board, and that is, as the number of medically complex patients increases, it becomes more difficult to determine true infection versus colonization. Are you able to discuss any measures or work going on now to help differentiate colonization from true infection?
I think that's difficult because if you don't have like a gold standard diagnosis, you can't really measure that ever truly. Because you if you ever were to do like a research study on that, if you're trying to compare, essentially, I think what you're asking is what is the rate of accurate diagnosis, right? So accurate diagnosis of disease is compared to maybe detecting a bacteria in the absence of clinical signs and symptoms. So one, there needs to be a gold standard diagnosis in which you compare that to. And in some situations, we do have that. If you don't have that, what some studies I've seen has done is they have usually experts. And so they have maybe like 3 infectious diseases physicians where they will all each independently review the case, and they define the diagnosis as having a majority consensus that that is truly the diagnosis. And so, that's one way to do it. That's again from a research. Any measures or work are going on to help different. There is some additional research now going on in some, I guess, novel diagnostics. Really, what kind of pops into my head is going to be next generation sequencing. That provides a lot of good, I will say that provides a lot of information right now. Whether it's good is still yet to be seen. But that I think is a promising new technology that I particularly have interested in trying to understand as we refine it and apply it to clinical practice in the future.
I think a good point, Melissa, of what you say is it's important to treat the patient and not the culture result. And so, many times we're trying to determine, is the patient actually sick? Do we have a culture result, but do we have then evidence of corresponding illness? Now, when we have an immunocompromised patient, then that is really quite difficult because they may not act the same as an immunocompetent patient. But that certainly is a challenge. And I think probably why across the board in infectious diseases, you probably, the ID team usually stops antibiotics just as often as they start them, because of those questions where you begin it. And oftentimes, you'll see somebody that is on treatment and their overall condition isn't changing. When the antibiotic is stopped, their condition still doesn't change. So then, you're left then going in another direction, outside of antibiotics. But, that is a tremendous challenge that is present. But I think also it's being compounded by, and Matthew, you mentioned the, next generation sequencing, where now, and I think Alan Junkins was on the call as well, that, as we have these specimens that we are sending and having these more sophisticated tests done, all of a sudden we identify, a whole room full of pathogens. And then it's like, it may be pathogens we didn't expect, but now they're present in this culture result. So I guess that's the, a culture result or a laboratory result is a double-edged sword. First of all, you got to know what you're going to do with it, before you order the test. And then sometimes you get a little bit more than you bargained for with some of these tests.
Mm-hmm. Yeah, no, it's it could be, the next I guess great era of healthcare, or it could be Pandora's box, and we'll see.
Yes, very good. All right, any additional questions? I don't see any more in the chat. And I really appreciate your time today, Matthew. That was excellent. And I'll just remind those that are interested in this statewide antimicrobial stewardship program. If you want to participate in this program, I know that there's a lot of outreach going on now to try to find individuals who serve as the lead for a variety of facilities. It's not just in acute care, but long-term care as well, and some of the outpatient setting, especially when your outpatient clinics are mapped back to a particular facility of one kind or another. So we want to really engage and be able to work on this as a state, because again, as we transfer people back and forth, whatever goes on in any facility is going to impact the health and safety and the care across our entire community. So this really is a group effort. I saw that Dave put information in the chat about the place where we are housing all of these videos on YouTube. If you have a moment and can go to that site, if you'll click on it, and then if you will sign up, if you will join the YouTube group, then that will help it become easier for others to find. So when they begin to search for Grand Rounds, once you have a group of, I think it's 50 subscribers, then you kind of bump up your status in how easy it is for others to begin to find that. And our goal is for each of you to be able to use these as part of your individual education with your groups at your facility, maybe something to kind of gather around and listen to the videos that may prompt a discussion, and it may also prompt ideas that you have. If you have an idea for a future Grand Rounds, please send them to one of us, and we will reach out if you have an idea for someone you think is a great speaker that can convey that information. We would love to reach out to them on your behalf, or if you would like to reach out to them and just send us the information, then we can work with them to make this happen. So thank you, Dr. Song. Again, thanks to each of you for joining us, and we will see you next week, same time, same bat channel, and we'll look forward to sharing additional information. Thanks very much.
Thank you.